Good morning. First off, before I begin, I want to say a quick couple of thank yous. First off, I want to thank the people at Snowasis, in particular Matt Burns and Rob Toffee, for putting this together. Matt did an amazing job handling all the logistics of putting this together, and I really appreciate it. I guess before I begin, I want to tell you a little bit about me. My name is Bob Miller. I'm a private practice periodontist. I practice in a place called Plantation, Florida. That's just north of Miami, south of Palm Beach, and just west of Fort Lauderdale. I graduated the Boston University Perio program back in 1986 and have been practicing in Plantation since August 1st, 1986. I also have a teaching position at the University of Florida. I'm involved, as you might have guessed, the perio part as well as the implant dentistry part. I also am very, very proud to say that I'm an ITI fellow. Now, before I begin my presentations, I like to start off with some sort of a saying or a quote that I think is relevant to the topic we're talking about. I think most of you have heard of Warren Buffett, and he once said that someone's sitting in the shade today because someone planted a tree a long time ago. Now, this is relevant to a lot of different things, but in particular, if you start thinking about implant dentistry as well as guided bone regeneration, we're using a lot of the same principles that were put forth in the late 1970s, early 1980s. Now, granted, the biomaterials have improved, the techniques have improved, but a lot of the same principles are still relevant today. Now, the title of my presentation is The Facts, Frustrations, and Fantasies of Simultaneous Implant Placement in Guided Bone Regeneration. And obviously, I'm going to sprinkle in a lot of my own personal cases using the BioXclude membrane. But what I'm going to do is I'm going to break this talk up into a couple of small parts. The first thing we're going to do is we're going to talk about a retrospective and the need for successful regeneration. And I firmly believe that you cannot be placing implants successfully unless, of course, you're successful at guided bone regeneration. I think it goes hand in hand. The second thing we're going to do is we're going to talk about indications for immediate placement and GBR as well. And believe me, there are a lot of indications for it, with and without guided bone regeneration. And then lastly, what I want to do is I want to talk a little bit about a bone defect classification scheme, almost like a decision tree. So when you look at a case, you can determine whether or not immediate placement can be successful. Now, what I'd like to do is I'd like to kind of hold up on the questions until the end. We'll definitely have a significant Q&A at the end. But obviously, if there's something that's really, really pressing, feel free to ask me. Now, again, I talked to you about, I graduated the BU Perio program back in 1986. And I guess back then the programs are 2 years, about 2 years long. And there was no such thing as implant education at all. So what I wound up doing is I wound up taking the Bronnemar course back in 1987. And I was saying earlier, I feel very blessed to have been brought up in the period where implant dentistry was just in its infancy. So I feel very lucky to have seen a lot of trends in implant dentistry kind of come and go. And I think it kind of puts me in somewhat of a unique perspective, gives me a unique perspective on it. Now, I remember back in my program, an article came out by Dr. Bronnemar in the Swiss group. And it was the first article of its kind. It was published in 1981. And it basically was a 15-year retrospective. And think about that. 1981, you're looking at the mid-60s where they discussed the efficacy of implant placement. okay? And it was the first time they discussed success rates in a refereed clinical journal. And in my mind, that changed the course of dentistry in many, many, many different ways. About 1987, when I took the course, a book was published. It was called Tissue Integrated Prosthesis. And that was kind of our Bible back then. And it was some 300 pages long. And if you start thinking about a 300-page Bible on everything you needed to know about placing dental implants, crazy to think about. But one of the most interesting parts about that book was the initial protocol. And the initial protocol called for the removal of all hopeless teeth. You basically debrided the area of any soft tissue remnants. And again, remember, there was no such thing as GBR back then. And essentially what we did is we allowed it to heal for up to 1 year. And then, and only then, you can consider placing your dental implants. And basically in the maxilla, we buried our implants, let it heal for 8 months. In the mandible, we buried our implants and let it heal for 6 months. Now, if you start doing the arithmetic, that adds up to 18 to 20 months before you actually uncover your implants and begin the prosthetic phase. And I can remember talking to my patients back then and saying, you know, listen, here's what we're going to do. We're going to take your teeth out. We're going to let it heal. We're going to put the implants in. And then it's basically a 2-year treatment plan. And patients would look at you like you had 2 heads. I mean, think about it. We want everything yesterday. My patients don't buy green bananas. You know, the bottom line is we want immediacy. No question about it. Now, a little bit later, about 1989, an article was published by Dr. Richard Lazzara. Dr. Lazzara is the founder of 3i, Implant Innovations. He published an article, I think it was the International Journal of Periodontics and Restorative Dentistry. And he basically talked about, for the first time in literature, the concept of extracting a tooth and placing an immediate implant. And I truly believe that this was the impetus for the worldwide universal acceptance of dental implants. Because basically, you know, think about it. If we didn't have this sense of immediacy, immediate placement, immediate loading, immediate provisionalization, I sincerely doubt that you'd have the Academy of Osseointegration, the bottom line. So I truly believe that changed the course of implant dentistry, this concept. So now, today, we take a tooth out, we get good initial stability, we can put it in a relatively good position. You know, that's what we're doing on a day-in, day-out basis. 2-millimeter gap type lesion, we're grafting it, we're doing this, we're doing that. And that's how the standard of care goes with implant dentistry for many, many, many people. Now, another interesting article that actually made me scratch my head and think is this is put out by the Swiss group, Danny Boozer, H.P. Weber, and the guys from Bern, Switzerland. And they estimate over 40% of all the implants placed require some form of guided bone regeneration as part of the rehabilitation or prior to implant placement or simultaneous with implant placement. And I actually, when I take a good long look at my own personal practice, what do I see? I put a fairly reasonable number of implants in every year, but what do I do most of my days? I'm taking patients who are marginal candidates for dental implants, and I'm hopefully turning them into good candidates for dental implants. That's my goal, and that's what I do most of my day. And I contend that if you're not successful or doing your GBR predictably, your implants are going to suffer as a result of that. And what do I mean by successful horizontal and vertical augmentation? I just don't mean for a picture like this, the day of uncovery. I like to see patients with longevity. Okay, this is one of the first this Noasis product that I used. It was called BioCover at the time. Did it in 2012, and this is the final X-ray at 2023. Unfortunately, the patient passed, so I guess the implant lasted his lifetime. But at the end of the day, predictability also includes longevity for me, not just for the day of the picture. Okay? Now, this is a diagram that's found in the ITI treatment guide. Volume number 1, it was put together by Danny Boozer, Will Martin, a number of outstanding clinicians. And what they wanted to kind of look at was, what are the factors that influence clinical success? Okay, and what they did is they boiled it down to the patient, the clinician, the treatment approach that you use, and the biomaterials that you choose. And it's essentially an interplay between these 4 factors, which is going to determine whether or not you're going to be successful. Okay? Now, each one of these 4 factors have modifying factors, which make each case unique. Patients, let's face it, all patients are not created equal. They have different risk factors. Susceptibility to periodontal disease, susceptibility to caries, occlusal risk factors. Are they clenchers, grinders, bruxers? Let's face it, patients don't lose their teeth because they're good dental patients. They lose their teeth because they're not such good dental patients. Okay? Medical risk factors. Are they immunocompromised? Are they taking bisphosphonates? Are they smokers? Jury's out, no question about it. If your patient is a smoker, they're going to have a lower success rate when it comes to implant success as well as bone yield for guided bone regeneration. Clinicians, we as clinicians are not all created equal. We have different experience level, skill level, judgment. Listen, I'm here because I want to become a better clinician. I want to learn from you guys as well. We all want to become better. That's why we come to these meetings. Treatment approach. Also, there are sometimes procedures or therapies that even the most skilled clinicians have trouble delivering predictability, and it's going to affect your clinical outcomes sometimes. But biomaterials, I think, is the most unique of the 4 factors. I truly believe that there's a difference. I believe that there's a difference in surface technology. I believe that there's in our dental implants, I think there's a difference between a Tier 1 implant, a Tier 3 implant. Like I said, surface technology, how the parts and pieces fit together. I truly believe there's a difference. And I also believe that there's a difference in biomaterials. And we have to choose our biomaterials appropriately. And I truly believe that in terms of guided bone regeneration, it makes a difference. But the unique part about it is you can't necessarily pick the patients coming into your practice. You don't have a choice sometimes, but you can elect not to treat them. Our experience level is our experience level. Sometimes we're locked into treatment plans that may be less predictable than others, but we have complete control and choice of our biomaterials. And I think it's really important to recognize that, particularly in guided bone regeneration. So a case like this, okay, I have a small dehiscence type lesion on the buccal aspect of that implant. I'll go through the protocol in a few minutes, but we can graft that area. I use a freeze-dried bone allograft. I use a DMD 70-30, 80-20 mixture. I place my BioXclude membrane on top of that. And then ultimately, 3 to 4 months later, we uncover that implant and we'll reestablish that buccal plate, okay, and hopefully root eminence. So that, to me, is something that I need in my armamentarium. Okay? Now, what is BioXclude? BioXclude is basically an Amnion-Chorion membrane. It's harvested from patients who have had cesarean sections, that they've donated their placenta, and there's a proprietary method in which they process it. Essentially, what they do is they remove the epithelial layer as well as a spongy intermediate layer, and then ultimately laminate the parts together. But the unique and great part about this barrier membrane is it has some 300 different growth factors. 300 different growth factors. And the way I look at guided bone regeneration, I'm a simple guy, and I need to look at things simply. I look at it as a race. I don't know how many people here remember the old tortoise and a hare thing. The tortoise being the slow-growing bone, the hare or rabbit is the rapid-growing epithelium. And so what we do traditionally is we handicap or slow down that rabbit to allow the tortoise, the bone, to regenerate, to grow unhindered, okay? Well, the way I look at this, the way BioXclude does, is it accelerates the healing. So for me, you're sort of juicing up the turtle, if you will, to regenerate a little more quickly. It accelerates that type of healing. So to make a lousy, who was I talking to about baseball a few minutes ago? Anyway, I see it as like we're corking the bat, so to speak, using the BioXclude membrane. Okay? That's the way I kind of perceive things. Like I said, I'm a simple guy. Now, I choose this for a number of different reasons. It's immunoprivileged, anti-inflammatory, accelerates healing, bacterial, antibacterial. So cases like this, and also there's a number of different choices. We have 8x8, 12x12, 15x20, 20x30. We have a variety of different choices and sizes that will accommodate most of your bony defects that you're dealing with. So we can use a slightly larger 20x30 membrane for a case like this. This is a 4-unit tooth-borne bridge that the anterior and posterior abutments is washed out. Number 17 and 20 had washed out. The treatment plan here was to remove those 2 teeth, okay, and hopefully place implants in position number 18 and 20. Okay, so we remove those 2 teeth. You can see we have a fairly significant buccal dehiscence on the buccal aspect of the implant in number 20. You can see the saddle area is kind of thin. And so our plan was here to hopefully place implants simultaneously and perform a simultaneous GBR procedure. Okay? So what I typically will do in these situations, I'll make sure that my osteotomies can place my implants in a restoratively driven position. I'll do some cortical perforations prior to putting those implants in to sort of recruit those pluripotential cells from within. Then I use the freeze-dried bone, min-D-min mixture of bone. And then what I do is I'll take that BioXclude membrane, and typically what I'll do is I'll take a little eyedropper to moisten the membrane so it just goes right into place. You don't need to tack it down, you don't need suture it down, nothing of the sort. Allow things to heal, and I close over using some horizontal mattressing sutures. Obviously, I want to reflect the flap and release the flap both buccally and lingually so I get primary closure. I use some horizontal mattressing sutures, some simple interrupted sutures. That's a 1-week post-op. 3 months later, we go back in, and then we open the area up, and you can see we're able to regenerate that buccal plate really, really, really nicely. Also, the saddle area was also regenerated really, really nicely. I take a CBCT. This is the buccal aspect of the implant in position number 20. Okay, again, very gratifying. And then I'll take a cross-section just anterior to the mesial to the distal abutment, and you can see we're able to regenerate that buccal plate as well. Okay, now, proof is in the pudding. Here's our 2021 radiograph at the time of restoration. And this is a 2023 radiograph as well. Now, we have a number of choices that we have to make and decisions that we have to make in the process of determining whether or not we should be placing our implants immediately into defects, or should we be considering a staged approach. Okay. First and foremost, for me, if the implant isn't restoratively driven or prosthetically guided, you should not be placing your implant simultaneously. You should be considering a staged approach. I think that's got to get that out in the open. All right? That to me is what I would call a deal breaker, if you will. So implants have to be prosthetically guided. Now, there are a number of different factors that we have to look at in terms of site evaluation. We have to look at the soft and hard tissue quality, quantity, and morphology. Obviously, aesthetic expectations. If it's an anterior tooth, we've got to make sure that we can deliver what the patient wants or is expecting. Okay? And lastly, we have to also attain adequate initial stability of not just our dental implant, but we also have to attain good initial stability of our graft as well. Okay? That all has to be taken into consideration if you're going to consider immediate placement. Okay? Now, here's a case, upper left. We have a 3-unit tooth-borne bridge, which is obviously failing, and then the teeth in position number 14 and 15 are also failing. This slide here is, I think it was, I don't know if Jeff Ganellis is here, but I think his concept, that's called Braden-guided implant placement. They are in the middle frame there. But the plan here was to remove 13, 14, and 15. We graft that area because obviously immediate placement really wasn't in the cards. And so for me, this was a very good choice and nothing to be ashamed of if you can't place your implants immediately. But the bottom line is I want to place 2 implants here in a restoratively driven position. I'm going to graft it. Again, I use a min, D-min, a mixture of bone. My BioXclude membrane goes on top. And in these situations, when I'm not placing implants immediately, oftentimes I can leave this site open, and you can see how the soft tissue will regenerate and really nicely on top of that. And then I can ultimately place 2 implants in the upper left and ultimately allow those to heal. And we go from a situation like this on the left with 3 hopelessly involved teeth to a really nice implant supported restoration, and with implants placed in the appropriate positions and the appropriate sizes and diameters. Another thing that I want to emphasize, okay, particularly in our anterior implant placement, is you want to place implants within the bony envelope, okay? Now, these are literally 2 cases that came across in my office literally in the last month. And I'll be upfront and honest with you. If any of us in the room placed an implant like that, how many thinks that it would last long enough to get these radiographs? But anyway, it's still in there. I'm going to be taking that one out shortly. This is the second one. This one poses a little bit bigger of a problem because it's literally within the floor of the nose. So I'm a little bit, I don't know if I'm going to leave that to Dan. Maybe Dan will take that out for me. A lot of vascularization up in that area, so I don't want to cause any problems. But these are cases that I don't know what they were thinking about. Other cases like this, we have a situation where we lost a cuspid, but again, I'm placing the implant well within the bony envelope, so for me, this is a very predictable type of a procedure. BioXclude membrane on top of it, allow it to heal, and then I get to play the game, let's find the dental implant, which is never a game that I'm not happy to play. So I feel when I approach a patient and we start talking about the concept of extracting teeth and placing implants immediately, I personally feel that I'm going to get a higher percentage patient acceptance. Why? Because you're going to offer them fewer surgeries. You're also going to offer them a shorter treatment time. All right? And what patient comes into your office and says, listen, can you take my teeth out and let's do this over multiple surgeries? I don't care if it takes 2 years. But the bottom line is patient acceptance is there. And then the other piece to this equation is the concept that for us as clinicians, if we can perform more procedures in a given allotted amount of time, predictably and successfully, it adds to our productivity. So it's a win-win situation when it's possible. So both the patient is happy about it, and we're more productive during our chair time. So I think those are two big things that need to be kind of thought about. Now, indications, particularly from our COVID perspective. Since COVID, we've had a lot of patients who've ignored their dentistry over the last couple of years. A lot of patients. And so we're getting a lot of cases like this, root fracture, okay? You can see the little fistula on the buccal aspect of number 8. And patient comes in, the crown's loose, we suspect a fracture. We open up, we remove the crown, we can see, if you look real closely, you can see a vertical fracture there. And these are the cases that are walking into our practices right now. So for us, we take the small pieces of tooth out, remove the remaining fragments of tooth, and then we go ahead. When you look at this clinically, what do you see? You see the soft tissue sort of draping down a little bit. So we're suspect that this tooth has some compromise to the buccal plate. Okay, we go ahead, we open up the area, and try to use a papilla-sparing incisions, and we can see that there's a compromise to that buccal plate. Next step here is to see if we can place this implant in a restoratively driven position. So the first thing I'll do is I'll go in with my 2.2 millimeter twist drill. I can see that I can get reasonable initial stability, and I can place the implant appropriately. Ultimately, I place a dental implant. It's well within the confines of the bony envelope, and essentially what I'm going to do is I'm going to graft that buccal aspect of that implant. Place my 12 by 12 BioXclude membrane on top of that, close over, and in this case I use the ceramic abutment. Tissue likes metal, likes titanium, but it loves ceramic. I get some really, really nice healing here. Go ahead and ultimately restore it. All right. Patient was ecstatic. He got his tooth within 4 months, and he was very happy with his aesthetic outcome. Actually, I think the implant crown looks better than his natural tooth, and the patient was extremely gratified and happy. And again, a happy patient refers their friends. So I think this is something that we need to be able to offer our patients. Next thing, residual roots. We see a lot of these walking into our offices these days. A patient had a crown, fell off, COVID, they didn't have it placed, and then the root tips start decaying, and ultimately this is a case that we're going to pop out a couple of root tips. And for me, the intraradicular bone wasn't this is something that I opted to go ahead and just graft the site, place my BioXclude membrane on top of it, let it heal. I wasn't afraid to keep it open because of its anti-inflammatory properties. The area healed up after about 3 months, open up the area, and I'm able to place a nice dental implant for this patient. Tissue level implant. This is some healing. This is some of the CBCT that we had taken, regenerated everything nicely. And if you knew this woman, you'd understand why she wanted a tie-dye crown. Like I said, you know. But anyway, that's her personality. She's a hippie from the 60s. But anyway, again, this is something, and there's no harm or shame in doing things staged. It's something that we can do on a day-in, day-out basis. I do these types of procedures very rarely where I place my implants immediately into molar sites, but in honor of the last lecture on osteodensification, VersaBurrs, I did use my VersaBurrs here. This is probably 1 of 3 times that I've done it, and in maxillary or mandibular. But we were able to get a very nice stable implant within that bone. Use 2 8x8 pieces of BioXclude on the mesial and distal aspect. I opted to close the area primarily because I thought it was important to kind of keep things closed, but that worked out very well for us. Trauma. Oh no, this is the congenitally missing teeth. We're also getting a lot of these in the office. If you work with orthodontists, you see these also quite frequently. This is a kind of an interesting case. If you look real closely, you can see somewhat of a concavity on the buccal aspect here. And if you look at the sagittal section, you can see how that kind of thins out. But if you look more closely at the volume rendering of it, you're going to see what appears to be a fairly significant buccal concavity on the labial aspect of number 10. So there were no promises when this patient came to the office, but you can see how it thins out midway between the cuspid and central. When we start looking more closely at it, well, let's take a look here. This is kind of synonymous with the occlusal view, the sagittal view, and you can see somewhat of a concavity there. If you look more closely at the buccal aspect, what you're going to see is a much more pronounced concavity. Okay? And what I like to talk about with my residents is the concept of three-dimensional implant placement. In other words, we're all concerned, everybody's concerned about the buccal lingual orientation of the implant or the mesial distal positioning of the dental implant. But what's probably equally, if not more important, is apically occlusally. If your implant isn't deep enough, you don't have room for your restorative abutment or restoration. Okay? So oftentimes we find ourselves having to remove bone in order to allow you to place your implants 3 millimeters apical to the adjacent CEJs. I created my osteotomy. I saw that I'm going to have a buccal dehiscence type lesion. Went ahead, made my cortical perforations, placed a 2.9 millimeter diameter implant in position number 10. Okay? And again, apical to the adjacent CEJs. I used the xenograft on top of that area, and the reason why I did that is for a variety of different reasons, because I was more or less hoping for a root eminence. Okay, sometimes you're concerned about the restoration, or the picture, but the tissue is the frame around the picture. Okay, so I decided to use some xenograft on top of that. I placed my BioXclude membrane on top of that. Okay, and then what I did is I actually placed a porcine pericardium membrane on top of that. And the reason why I go back to the concept of choosing your biomaterials appropriately. Now, xenograft has a lot slower turnover rate, so we need to maintain that barrier function for a protracted period of time. If we don't maintain that, you may not get the bone yield that you're looking for, because obviously BioXclude is going to resorb more quickly. Porcine pericardium membranes usually stick around for anywhere from 3 to 6 months. So that coincides with the xenograft, which obviously has a slower turnover rate. Place my membrane on top of that, and again, it's layered with BioXclude, closed over, allowed things to heal, and that was the day of insertion of the restoration. This is the CBCT of the day of insertion, and you can see a buccal plate forming. Now, I don't want to mislead anybody, but again, remember, that's a xenograft, and xenografts always look good on CBCT after 3 months. Okay, I mean, I don't want to make any things a little pretending here. But bottom line is, let's take a look at it a couple of years later. Here's a 2021, and this is at 18 months when we saw them. And you can see tissues are maturing a lot nicely. This is 2023. So we are maintaining that buccal plate. Whether it's still the radio opacity of the the xenograft, I don't know, but I'm still going to take credit for it. It's okay. Anyway, congenitally missing teeth. Another thing that we're seeing a lot of on occasion is trauma cases. This is a trauma case that was sent to me by a dentist in Hollywood, Florida. And this is a woman who, really nice woman from Philadelphia, who actually had a vasovagal attack, sort of fell on her face, hit her sink and knocked out her front teeth. Really horrible accident. This is a day after the procedure. I saw her as a new patient at that point, and we sat down and started treatment planning her. This is the occlusal view, and this is the radiographs. And you can see just how much those teeth had luxated, how much movement that you had here. And so the treatment plan here was to kind of open things up because the teeth were literally falling out at this point. We immediately removed tooth number 8 and 9. You can see we had root tips up there. Buccal plate was completely fractured and dislodged. The buccal plate was also problematic on the labial aspect of number 7. And then what I did was I said to myself, is it possible to place these implants simultaneously? Is this a possibility? Is it something that I can do? Okay? So the next step for me is actually going in with my twist drill, just to see if I can get apical stability, number 1. And number 2, are the implants going to be placed still within the bony envelope? And can I place them in a restoratively driven fashion? And which I was able to do. So for me, the next step here was I considered an implant in position in the central incisor position using an allograft bone ring. I'm not sure how many people here know about the allograft bone ring, but basically it's a machined piece of cancellous bone. It's cylindrical in fashion. It's either 6 or 7 millimeters in diameter, okay? And it'll accept, the donut hole will accept either a 3.3 millimeter diameter implant or a 4.1 diameter implant, okay? So we go ahead and we create our osteotomy using a trephine, which corresponds to the diameter of your bone ring, either 6 or 7 millimeters in diameter. And then what we do is we use something called a planator drill, which flattens the floor of the osteotomy. Now, again, those are 14 millimeter twist drills that were used to 14 millimeters. So I had apical native bone. I had the osteotomy that I created with my trephine. So that's a pretty solid implant graft unit at that point. And we all know what leads to success with grafting and implant placement, that it being solid. Now, the implant in position number 7, I performed what I want to call conventionally, okay? And you can see, again, it's the bone ring is well within the bony envelope at that point. Now, the implant in position number 7, I opted to graft conventionally with my freeze-dried bone allograft and a BioXclude membrane on top of that. All right? There's my BioXclude, and you can see. Now, the protocol, I was one of the educators for bone ring, and what we did is I decided that I'd go ahead and use my appropriate protocol for it, meaning we placed the xenograft on top of Giesenhagen and Thomas Nord, who originated the procedure in Germany. They called for a xenograft on top of that and a conventional collagen membrane draped over on top of that as well. I was able to get good primary closure. I released the flap adequately. Again, horizontal mattressing sutures with some simple interrupted. Went ahead, the dentist in Hollywood made a lab process provisional, so there was no pressure on my grafts, 0 pressure on my grafts. And we allowed that to heal by 4 to 6, I forgot how long it was, 6 months maybe. Anyway, the patient went back up to Philadelphia to have a restoration, and this is the final result. You can be your own judges. I know we have some laboratory technicians, and I see them turning green. But that's a 2019 X-ray, which is us surgeons. All we care about is the radiographs, you know us. So we have 2019, 2021, and here's a 2023 photograph of it, and these are the CBCTs, which is what I call our report card. and we're still maintaining a really, really nice buccal plate as a result of that. And I can honestly say that this is one of the more grateful, happy patients that I've ever met. She's just happy she has front teeth. Extremely happy. Now let's go over a bone defect classification scheme. Okay? There's nobody who's done a better job at putting this together than the NYU group. Elian, Stephen Chu, Dennis Tarnow published on this several times. And what they did is they broke it down into 3 different parts. Type 1, Type 2, and Type 3 extraction sockets. Type 1 extraction socket, we have an intact buccal plate and intact soft tissue. Okay, that's Type 1. Type 2 extraction socket, well, we still have intact soft tissue, but we have a compromise to the buccal plate. Type 3, we have not only recession, compromise to soft tissue, we also have compromise to our buccal plate. Now let's review these 3 types of extraction sockets. Type 1 extraction socket. Well, those, like I told you, good soft tissue, good bone. Pretty much we're going to place our implants immediately, again, if we can place them in a restoratively driven fashion. And we can place those implants with or without guided bone regeneration. And to be honest with you, I get every now and then, I get lucky and I get a case like this coming into my practice. We have a nice thick gingiva. We have a beautiful, you can see a really nice buccal plate at the end. This was referred to me by my endodontist and saying, Bob, there's no way I'm doing root canal on that tooth. You can pull the finger out with your fingers. And so this was slated to be extracted. We extracted the tooth, placed the implant simultaneously. I'm really not sure what was going on with that root, but we grafted it with we had a small dehiscence type, small gap type lesion on the buccal, and I placed a little collagen in there, allowed it to heal, and we went from a situation like this to some nice thick buccal plate. Again, remember, we had a nice thick buccal plate to begin with, and this is the final restoration. Very, very happy patient, matches the teeth rather nicely, and you can see some follow-up x-rays. Let's take a look at a type 3 case. Type 3, generally speaking, remember, we have recession, and we have recession, and we also have a compromised buccal plate. Well, in those situations, we can extract the tooth and sometimes place our guided bone regeneration simultaneously. Sometimes. Sometimes our soft tissue is so compromised that it's not the right thing to do because we want to regenerate some of that keratinized tissue. But in cases where we can extract it and do the GBR simultaneously, we place our implant after initial healing at about 3 to 4 months. Now, what happens if we have a compromise to that soft tissue? Well, what happens is we have to consider a delayed GBR procedure because we want to regenerate that recession, that keratinized tissue. And then, once we regenerate it, we can perform our GBR procedure and either place the implant after maturation, or we can do it simultaneously and place it at the time of the GBR procedure. Okay? So let me show you a case like that. Here we have a situation where the upper right cuspid sort of gone through the mill. Several endodontic therapies, treatment and retreatment, apical surgery, and we have some significant recession, a lack of keratinized tissue. So what am I going to do here? What I'm going to do is I'm actually going to extract that tooth and allow it to heal for 6 to 8 weeks. Why? Because I want to regenerate some of that soft tissue because, to be honest with you, I'm not going to be able to close that, okay, without adequate keratinized tissue. So that becomes a big part of the treatment. Go ahead, open up the area, and what do I find? I find a fairly significant dehiscence type lesion, but I can still place the implant within the bony envelope, okay? and I can get adequate initial stability and place it in a restorative-driven fashion. So I'll graft it. I'll go ahead, place my BioXclude membrane on top of it. All right. Allow it to heal, and then I've regenerated that buccal plate. Okay. And then we go to completion, and you can see how nicely that's restored. I've not only restored the buccal plate, but I've also have a nice thick zone of keratinized tissue at this point, and I'm very confident that this should last, that should stand the test of time for this particular patient. Okay? Now, let's take a look at type 2 extraction sockets. The NYU group broke that up into 3 parts as well, Stephen Chu. Basically what he said, we have a type 2A, 2B, and 2C. 2A has a moderate facial compromise, a type 2C, a more significant, and a 2B, a more significant, and a 2C, a very severely compromised buccal plate. All right? So let's take a look at this. Well, a type 2A, here we have a patient, terrific young guy, 22, 24, had some trauma, some root resorption was occurring here, so the tooth has to be extracted. Again, these are cases when they have this type of a smile line, where those are the cases that keep most of us up at night. Remove the tooth, and if you look closely at the last picture, you can see we're probing that buccal plate over there. So we know we have a little bit of compromise to this. So I'll go ahead, I'll make my papilla-sparing incisions, I'll graft that dehiscence type lesion, place the nice BioXclude membrane on top of it, allow it to heal, and then ultimately we go to completion, and we get something like this, matching up the gingival margins quite nicely, and obviously this is a pretty happy patient at this point. And again, that's our aesthetic result. Here's some x-rays from 2020 to 2024, all showing nice maintenance of that buccal bone, of the bone around the implant. Type 2C extraction socket, a little more significant. We open up the area, we can see some really significant buccal plate compromise. This is something that I'm going to go ahead and I'm going to graft. I grafted with this was a mineralized freeze-dried bone. This is prior to me using Min-D-Men. And we grafted, BioXclude membrane on top. That's what it looks like at 1 week at the end here. That's a 1 week post-op. Allow things to heal, re-enter the site, and we've regenerated some nice bone, able to place our implant, and we wound up going to completion. Here's our 2020 x-ray, and our 2015 x-ray, and this is our 2020 x-ray. Patient moved out of town, so I've lost track of them. But that's a very typical 2C type of a case. 2B cases are very, very common in my practice, a fairly significant dehiscence type lesion. In those cases, what am I doing? I want to graft those, okay, if I can place them immediately. Graft it, BioXclude membrane on top, and then we get a nice knuckle of bone, able to, again, play let's find the dental implant, and that restores out nicely as well. This case is anywhere from 2017 to 2022 was the last time I saw him. I want to end on this case here. This is a kind of an interesting case. Really, really nice woman. She had some restorations completed, mostly veneers, but unfortunately, tooth number 8 was no longer restorable. Wound up basically washing out. If you look real closely at this CBCT, you can see a thin isthmus of bone. And you can see where I guess the apical surgery had been performed. So we know we have an apical fenestration. So I wound up, again, papilla-sparing incisions, and I removed the tooth, what I call atraumatically. Now, I once said that with a group of oral surgeons, and they told me, well, nobody removes teeth traumatically. And that I remove teeth traumatically, no matter how you look at it. But I was able to preserve that isthmus of bone, which is something that I really wanted to do. Grafted this, first I went in with my 2.2 millimeter twist. I was able to get the implant what I consider in a reasonable position. And my goal was to kind of hopefully build up that buccal plate and cover that apical fenestration. I placed a BioXclude membrane on top of that, draped it on top, and then what I did is I opted to use my porcine pericardium membrane. And you might ask me why. Well, for me, it was more the purpose of providing no micro movement to my graft. And I wanted to make sure that I maintain that barrier function for a protracted period of time. And typically what I'll do in those situations is that I'll actually suture my membrane down at that point. So I'll engage the periosteum deep into the buccal flap and then tie it down so there's no micro movement to it. And I think that is key to hopefully regenerating some nice bone around it. Closed over, allowed it to heal, placed a longer transmucosal abutment on it, and we have what I consider a very, very, very happy patient at this point. And again, looking at 2021, 23, and we're able to restore that in a reasonable fashion. Now, the question becomes, where do we go from here? What are the take-home messages here? Well, for me, the take-home message is, number one, first and foremost, we need to have a prosthetically guided implant placement. First and foremost, you should not be placing your implants if you can't, if there's any compromise to that. Two, I'm a firm believer that we also have to treatment plan for keratinized tissue. If this was an all-day lecture, I'd be showing you how I add keratinized tissue to 90% of my dental implants that I place. I'm a firm believer in that. I also firmly believe that you can't grow hair on a bowling ball, okay? Meaning, if your implant is outside of the bony envelope, you're taking a big chance if you're going to try to graft it simultaneously. Big, big chance. So I'll do those in a staged approach. And lastly, you really need to be thinking consciously about the initial stability of your dental implant as well as your graft. Okay? So with that being said, I want to thank you all for your attention. I really appreciate it. And I open up the floor to any and all comments. Yes, sir.
With your residual roots, when you remove them and you get the rotational bone to narrow, what if you remove the rotational bone and graft in the whole socket, so you remove that? Okay, for me, it's a deflected.
What do you mean deflected?
Well, trying to come back and place the osteotomy down to the heel socket with the rotational crest on it. To what degree is that cause deflection of the pilot crest?
Oh, you're saying, in other words, after it heals, you're saying that bone will be more dense and deflect your drill?
Correct.
Either way. I've never noticed that. I've never noticed that, actually, to be honest with you. I'll go in with either a needle drill, which is a non-issue, or if I feel it's really dense, I'll go in with a small round burr and then go in with my needle drill. So I will actually, look at that. I told you I wanted to learn something. And I will try that. I've never noticed that as a problem, though. But I don't disagree with you. But I'll be more conscious of it. Is that what most people do? They remove I'll remove the intraradicular bone if I'm having trouble or the residual roots are extremely decayed and I can't get to them. Sometimes I'll remove that intraradicular bone. Or if there's curves and, things like that, I will. But these just literally popped right out, and I did not have an issue. But point well taken. Yeah. Anything else? Yes, sir.
With your villa preserving incisions, you make a lot more time with great results. But do you do that standard, or is it more photography?
Standard. I do that unless the bone loss or something is too close to, in other words, I can't, these just happen, and listen, it's a 50-minute lecture. I couldn't, I can only show so much. But I think one case I showed complete elevation. But truth be told, I'd say my initial way of looking at things, I want to try to preserve the papilla. I traditionally try to do that. If I can't, I don't. And I think the one that I did show was a 2.9 with a really compromised, was actually not, had very, very small teeth. And I used the 2.9, which I'm also not a huge fan of either. That actually I've gotten questions, well, how do you restore those? Because they don't make ceramic abutments for those. So what I'll do is I'll have them powder coated. I'll have the abutments powder coated. And that kind of works for me on many, many occasions. Good point. Yeah?
Since you're still using a lot of particulate graft material,
Yeah.
are you using any growth factors within the graft coating, or just hydrogen in place of the BioXclude?
These cases, I only just use BioXclude. I've been a big, big proponent of growth factors since Amnion-Chorion. A big, big proponent. That's actually what fueled me to look at BioXclude. Historically, for me, what I did was I had spoken with somebody who was sort of big in bone research, and Michelle Dard, I don't know if you know Michelle Dard, and a number of us looked at Amnion, which was originally used for GTR. Okay, and this was in the late 90s, early 2000s, and it kind of passed through Biora and this and that, and I used it for GBR, which is an off-label use. I was very, very familiar with BioXclude and the Amnion-Chorion membrane used for burn victims. And they use them for spinal surgery, ophthalmology, a number of different things. So I thought to myself, this sounded really, really familiar. Really like a very good idea. So that's how I actually sought out Snoasis in the late 2000s, early 2010s. And that's how I wound up with it. So I've always had that concept of juicing up the turtle, so to speak, because I think that's pivotal. I think that's important. There's a number of other companies out there, but BioXclude has been really, really successful for me because it's almost time released. Okay? In other words, it's not just a one-shot deal. You place Amnion or something like that, it's a one-shot deal. And it's also off-label. I've never really had. I've heard it's 4 to 6 weeks, which is very similar to BioGuide. I do believe that it's going to resorb more quickly. That's why I will use the secondary membrane sometimes in situations where I think it's important. I truly believe it. And I think BioXclude is a little more time release than a lot of the other options when it comes to that concept. Yeah.
Do you ever leave it exposed?
I did, several times. Yeah, and that's a result of the anti-inflammatory, that's the result of the anti-inflammatory qualities and properties of the material.
So how long do you think it lasts leaving it exposed?
Well, you know, it's an interesting thing. I've toyed with it both ways. I've actually toyed with, and I do have cases, I have probably a half a dozen cases where I actually place gel foam on top of it. And I've also placed socket plugs on top of it. And I really haven't noticed an awful lot of difference. The socket plug, the only reason why I kind of like that is because you're actually increasing the amount of soft tissue vertically. And if you're really looking to recreate, let's say your ridge is a little bit thinner than you like, and you want to create a nice frame around that picture, I might consider doing that as well. But again, it's a 50-minute lecture. You know.
Have you ever put PTFE over
No. No, I haven't done that. No, I haven't done that because then you're not sure which is really causing the good parts. So, short answer to your question is no, but sometimes the cases speak for themselves, you know, and those are all good questions. Anything else? Listen, I can't wait to hear Dan speak. I know you guys are going to really enjoy that.